region, which we will study together. It is the foot region. So we say that inside of the fatty tissue of the dorsal region, we have veins and we have superficial nerves. Veins is two here. Generally, they originated in this region. In the middle part, as you can see, we have the venous arch. Venous arch is located in the level of the distal head of the metatarsal bones. So from that level to the medial side, it gives the origin of magna. In the lateral side, it gives the origin of the parva. And it continues up to the one goes to the knee region and finish. Another goes up to the inguinal ligament and finish. So that's not news for it. About superficial nerves. Three nerves generally you see in this picture. Medially saphenous, laterally suralis, and between them peroneus superficialis. One nerve you didn't see. It is originated, not originated, come to fatty tissue just in the first interdigital space. It is peroneus profundus. First of all, it is supplied the tendons, which is located. It is long and short tendons, also short muscles. Extensor digitorum brevis, extensor hallucis brevis, which is located in the dorsal region of the foot. After this terminal branch of it, it is the sensory branch. It is perforated the proper fascia, come to the subcutaneous fat tissue, and start to innervate here, the skin. That's it. Keep it in your mind, guys. The medial surface of the foot, innervated by saphenous, lateral surface of the foot, innervated by suralis. Interdigital spaces, except first one, innervated by peroneus superficialis. First interdigital space, innervated by deep peroneum. Consider. Aswin, yeah?
Yes. Okay.
Thank you very much. Let's go deep. Let's go deep. Let's remove here the superficial and proper fascia. By the way, about proper fascia, it is fused here with the structures which is located deep. It is the tendinous structures, it is the muscular structures. It's covered them in the region of the fibrous sheets. It fused with the circular ligaments, not crucinate ligaments, circular ligaments. And it is make the reinforcing of these ligaments, make it stronger. Let's say it doesn't form the ligaments, but it is fused with them and make them stronger. Let's say there we say that it is fused with deeper structure. I don't mean that it fused immediately to the tendon. Otherwise, tendon will lose the movement. But it is formed. It is fused with the fibrous sheets, which is located in the level of the fingers. And due to it, it makes the fixation stronger. By the way, approximately same you will see in the plantar surface also, not only in dorsals. Under of it, there are two loose connective tissues, superficial and deep. Superficial located between the proper fascia and tendon of the long extensors. Deep one located under the tendon of the long extensors, generally between long extensors and the metatarsal bones, which is located here. What is located in superficial one? Tendon of the long extensors from medially to laterally. Tibialis anterior, extensor hallucis longus, extensor digitorum locus. Extensor digitorum locus split it into four tendons from second up to the fifth fingers. They reach up to the nail phalanx or the distal phalanx. They pass between two splitted legs of the superficial extensor and finally reach to the distal phalanx and fuse to it. The short extensors located under the long one. Now here you can see cutted portion of extensor digitorum brevis, little bit more medially we have extensor hallucis brevis. So this is two muscles which is located in the dorsal region of the foot. In the deep loose connective tissue, we have neurovascular bundle. You remember it is the arteria vena dorsalis pedis, two venas, to tell the truth, and it is nervus peroneus profundus. By the way, nerve is located medially in this level. Artery projected, as you remember, upwards, midpoint of intermalleolar distance, downwards.
First interdigital space.
And it gives three branches which you study in your anatomy. Arcuate branch, which is located approximately in the midpoint of the metatarsal bones. From arcuate, you can see we have the origination of our metatarsal arteries. Second, third, and fourth metatarsal arteries. Also, arcuate artery gives the separated branch to the lateral surface of the fifth finger. After giving of the arcuate artery, arteria dorsalis pedis continues to the first interdigital space. Here it is split into two terminal branches. First metatarsal and deep plantar branches, which is perforated structures, goes to the plantar surface, fused with the lateral plantar artery, and together they forms the plantar arterial arch, about which we will speak a little after. So keep it in your mind. We discussed before the nerves, now we discuss the vessels. Each metatarsal artery is split into two proper digital arteries. One will come to the medial surface, another come to the lateral surface. And finally, we achieve neurovascular bundles, one in medial, one in the lateral surface of the fingers.
Yes.
Totally two neurovascular bundles for each finger. That's all. Questions? If no questions, let's continue. Let's come now to the plantar surface, one of the thickest and not elastic and movable skins of the human body. Much more thicker it is in the proximal portion, in the region of the calcaneus. Less thicker it is in distal portions. Yeah, let's say then you come to the heel region, it is much more thicker. A lot of the sweat glands, because this is the sensitive zone. You know, here we have the tactile sensitivity. Let's say. It is work in the wet environment, yeah, you know, it must be wet to make the normal, proper, yeah, receptoral function. No sebaceous glands, general, no hairs. Subcutaneous fatty tissue, again, from upwards, great developed, downwards, it is disproportionately developed. It is good developed in the base of the fingers, in the region of location of the so-called commissural apertures. But just in the middle portion, instead of protrusion, we have vice versa, depression, arcuate shape form of depression. Here, subcutaneous fatty tissue is not good developed. Subcutaneous fatty tissue has pocketer structure. White septum, not superficial, but proper fissure, gives the septus, which is traversed through the fatty tissue, reach the skin and fuse the skin. That is the cause why skin become thick and why it is lose the movement. And due to it, of course, fat is divided into the pockets, and this is the cause why here inflammational processes is separated. Subcutaneous fat contains, again, venous structures, nerves. By the way, medially it is the same saphena magna branches together with saphena, not main trunks, but the branches. In the lateral side, saphena parva, nervus suralis. That is the structures which we have here. More of these. Medial and lateral plantar nerves gives the skin branches. One is come to the medial portion. Second, that's if previously mentioned structures innervated the margins, I mean suralis and saphena, plantaris medialis and lateralis innervated the skin of the plantar region immediately. By the way, approximately they divided the plantar region into two equal parts. In the region of the fingers, it is the 2 and half. 2 and half medial plantaris medialis, 2 and half lateral plantaris lateralis. Proper fissure also disproportionately develop in the region. The more upper you come, the more it's thicker, and inferiorly, it is better developed in middle portions. In lateral and medial parts, as you can see, it is transparent, it is not so thick, but in middle portions, it has a panevrotical structure, it is non-transparent, and it forms the so-called plantar aponeurosis. How plantar aponeurosis is formed? Tendon of musculus plantaris longus joined to the proper fascia inside of the plantar region. Together they form the plantar aponeurosis. Plantar aponeurosis approximately in the level of the proximal head of the metatarsal bone, split it into 5 bands. Longitudinal bands, each one goes to the base of one finger, and in the level of the distal head of the metatarsal bone, it is joined to the transverse fibers. Between transverse and longitudinal fibers, we achieve the commissural apertures. Commissural apertures make the communication between subcutaneous fatty tissue and deep loose connective tissue, which is located under the plantar aponeurosis. More of these, plantar aponeurosis gives two septa towards the same metatarsal bone. One is fused with the medial surface of our fifth metatarsal bone. Second is fused with the lateral surface of the second metatarsal bone, and they divided all space into three beds or three osteofacial compartments: medial, middle, and the lateral. Inside of the medial and in lateral, we have short muscles for first finger. It is the flexor muscles, short flexor of the fifth finger, together with adductor muscles in each one. In middle portion, we have the tendon of the long flexors, and also we have the musculus plantaris brevis, which is located inside of it. Super. Under these tendons, we have the, by the way, primary neurovascular bundles pass between splitted septas. Septa is split, it is not interfacial space. Just near the bone, septa is split into two layers, and neurovascular bundles pass inside of this splitted fascia. Why it is not interfacial space? No loose connective tissue. We don't have here loose connective tissue. We don't have fat. How they projected, you know, upwards it is midpoint of distance of medial malleolus calcaneus. Downwards for the medial one, it is the first interdigital space. For the lateral one, it is the fourth interdigital space. Plantaris medialis twice thinner, I mean artery, than plantaris lateralis, and generally it is supplied just the medial surface of your first finger. You can see it. It also gives the small communicating branch towards the plantar arterial arch, but plantar arterial arch primary forms the lateral artery. Lateral artery curved and goes from the lateral into the medially and from proximally to distally, reach approximately the base of the first interdigital space. Here it is connected with the deep plantar branch of arteria dorsalis pedis. They join to each other, they forms the artery which I show. It gives the plantar metatarsal branches. There are generally 4 plantar metatarsal branches. Why 4? Again I say, because for the lateral surface of the fifth and for the medial surface of the first, we have separate vessels. Medial surface of the first, it is from plantaris medialis. Lateral surface of the fifth, it is separated branch. Totally together with nervus plantaris medialis lateralis, which also gives the metatarsal and which is divided into proper digital, 2 1/2, we achieve formation of 10 neurovascular bundles. Yeah? One in the medial surface, one in the lateral surface. They, by commissural apertures, become usually, by the way, division is happen inside of the commissural aperture. Metatarsal vessels split it into the proper digital vessels. One is go to another, so one surface, another go to another surface. Come to the fatty tissue and continues by fatty tissue into the fingers. Let's say finally each finger achieve 4 neurovascular bundles. 2 in the dorsal surface. Dear, don't sleep, please. 2 in the dorsal surface and 2 in the plantar surface. If it is very painful, dear, you must to make the X-ray. Understand me, she has the trauma. That's if there are head traumas, usually you must make the X-ray, because by palpation I teach you previously, you cannot find anything. If the problem is internal, you cannot feel anything by just palpation of the external compact layer. That's it is important. It is important to not lose any intracranial disorders. Of course, anybody can understand, is it serious trauma or not? Doesn't mean that if somebody touched to your head, it means that immediately you should run to make the X-ray. But if it is something serious, of course, you need to make some instrumental method of investigation. That's all what I want to say you about foot region. My congratulations, we totally finished to study all topographical questions. Please, before I will start to explain for you the amputations. If you have any questions, I will be very happy to answer.
Sir, can you explain the collateral network of malleolus?
Malleolar network. It's very easy, guys. 4 vessels involved in its formation. 2 we call anterior malleolar, medial and lateral. 2 we call posterior malleolar, again medial and lateral. Anterior malleolar arteries originated in the lower third of the leg region from arteria tibialis anterior. They perforated the proper fascia, they come to the subcutaneous fatty tissue, and immediately in the level of the malleolus, they form the collateral network, which I mentioned. Posterior vessels have different origin. Medial one originated from tibialis posterior, lateral one from the peroneum. They come to the lateral and medial surface of the mentioned malleolus, and with anterior vessels, they form the collateral network, which we mentioned. That's all. 4 vessels. We have 2 anterior, 2 posterior. Nothing is hard. What else?
Thank you, sir.
If no other questions, my work is approximately into 20 minutes, guys. Let's come again into the amputational topic. As I told you before, we have the circular methods of the amputation and the flat methods of the amputation. By the way, nowadays I show for you the instruments which we use usually for the amputation. Of course, it is the amputational knives. It is different kinds of the saws. Generally, it can be hand saw, it can be the jimmy saw, and the special amputational retractor. What does it mean, amputational retractor? This is the instrument. It has the dish-shaped form with the hole in the midpoint. By the way, hole, of course, it is for the bone. So you inserted it inside of this aperture, and you apply this retractor into the soft tissue. Why it is necessary? Of course, to lift the structures to upwards. Because as I say you, the most useful method of the circular amputation, it is 3-moment circular amputation. What does it mean? Separately you cut its skin, separately you cut it the muscles, separately you cut it the bone.
Yes.
You know that each this structure which I mentioned has its constrictional, we can say, index. Skin constrictional index in the thigh region from 6 up to the 9 centimeter. Muscular constrictional index near the 4-6 centimeter. Bone doesn't have any constriction.
Yes.
That's why what is the benefit of this triple moment amputation? You achieve the prefacet of the soft tissues, which you use after to close the stump of the bone. How we do it? Generally, step number 1, we cut skin with subcutaneous fat tissue. We wait the 3-4 minutes until it is constricted and goes upwards. Little bit even you try to lift it also by your hands, and by constricted margin of the skin, you cut it the muscles, generally superficial muscles, yeah? Quadriceps, biceps, semitendinosus, semimembranosus. What it gives you? After the next 3-4 minutes, muscles also will be constricted and will go upper to the constricted margin of the skin. Because you cut the muscles by constricted margin of the skin. Now, let's, for example, touch wood. Of course, I don't like to show it in myself. Let's imagine that, for example, I choose the midpoint of my thigh region. I cut here skin. I must understand that after this, skin will be elevated into 7-8 centimeters to upwards.
Yes.
Yeah? It will be the final place of location of the skin. That's it. If I need to remove the extremity in the level of the upper third, I must to cut the skin much more lower, yeah, approximately the level of the midpoint, even a little bit shifting to down, because I know that skin will be constricted and goes to upwards. Okay, now it is come to that level. After I cut the muscles, I will understand that muscles after constriction into 4 centimeters approximately will go upper to the level of the skin. Friend, you understand what I tell you or no? Then I take this amputational retractor, I apply it into extremity, maximally lift these muscles. How much maximally? After constriction, again, into approximately 3-4 centimeters. Finally, the deep muscles, which is fused with the bone, together with the bone, I cut it in the last level. Of course, they will not be constricted. That's what I will have. Here muscle, 4 centimeter below, here the bone, 4 centimeter below, it is the muscular main bulk of the muscles. 4 centimeter below, we have skin. That's why it is the reversed stairs. Yeah, first stair, second stair, last stair. If you will make the uni-moment amputation, you will have the real stairs. First stairs, second stairs, third stairs. Because you cut everything in same level. Skin will be constricted maximally. Muscles will be constricted less than skin. But bone will be in the level of your uni-moment amputation. It cannot be constricted forever. Idea is understandable for you. You can say, is it possible to make single moment? Or what is double moment? Double moment, you understand. Also tissues you cut in one level, then also tissues you lift it and cut the bone. Generally, we achieve, unfortunately, upper level of the skin and lower level of the muscles. Bone will be located approximately 3 centimeters upwards. Say skin is not enough to close the stump. That is the problem. Can we use? Yes, of course. We can use a uni moment and double moment, but after I should make the reamputation. Say, to save the life, for example, non-in-hospital conditions, to remove the necrotizated structures, to prevent the intoxication or to prevent the bleeding, anything else, I can do it. But after, of course, I will apply the bandages. I will not close it forever. I will not anyhow suture the stump. Why? Because after I will need to make reamputation. And I told you before that is not the best option, because any next reamputation we will make the shortening of the stump of the extremity. Is it good method or bad method, circular? Good method, guys. Only in one case, if you will not have in the future high pressure in the lower surface of the removed extremity. Because you understand that anyhow your final stump, after the boring of the tissues to each other, suturing of the tissues to each other, final scar will be in geometrical midpoint of your stump. Let's say, if, for example, you use some compressional prothèse, which is primarily press the surfaces, not to downwards, or if it is generally upper extremity amputation of the arm region, for example, method is great, method is good, but if it is the simple prothèse of the lower extremity, which you wear inside of it and it is compressed the stump from downwards, it's not the best option. You can ask me a question. You can say, sir, why circular amputation generally we use for the extremity with single bone? Simply, guys, because all the previous mentioned manipulation primarily connected with cutting of the muscles and lifting of the muscles is impossible to be performed in the region with more than one bone. Because part of the muscles will be between the bones. And sorry, if you will apply a retractor and lift, they will not lift it to upwards. If you remember, tibialis anterior, tibialis posterior, flexors, extensors were between the bones. We don't have they surrounded of the bone. That's it. In the region with more than one bone, instead of the circular method of amputation, we make the flap form of the neck. And you can see, I give here example for you, which kind. First of all, of course, you understand that you can make single flap, you can make double flap. In case of the double flap, guys, again, you can make the equal double flaps. Again, in that case, the final scar will be in the inferior surface of the extremity. Or you can make unequal double flaps. In that case, the final scar will be in the size of the shorter flap. According, it can be posterior, anterior, medial, lateral. Doesn't matter. For example, we know that if we make just simple prothesing of the leg region, the best compression become to the inferior and anterior surface. Because you press your extremity from behind to in front. Let's say much more preferable to have the final scar in the posterior. Say, according to it, if you will use in the orthopedics practice, of course, you will know about it. Generally, I teach you now, not the indications and anything else, just techniques.
Yes.
Yeah, we have the special methods, how by the perimetrium, by the diameter to measure. I don't have now time, and it's not necessary, you will read it. But according to the structures, first of all, how we can prepare the bone. You can see that we make so-called aperiostal, subperiostal methods. Periostal preservation method, extraperiostal method. What does it mean and for what it is necessary? What does it mean aperiostal? For example, you come to the bone approximately 1-2 centimeters or 1 centimeter above the bone level. You cut the periosteum and you remove this periosteum from the surface of the bone. You leave the inferior portion of your bone without periosteum. Why it is that? It has advantage and disadvantage. Advantage of this method that we don't have formation of the osteophytes. You know that osteophyte, it is abnormal regeneration of the bone in the form of the sharp needles. Because the bone is cutting, osteoblast will start to produce in the bony tissue. It can form the bone spares, which can easily perforate it, damage the soft tissue. But what is disadvantage of this method? You can achieve during the time necrotization of the bone, because then you leave the periosteum from bony surface, and especially if it is compressional place. If it is non-compressional place, a periostal method is good. No any pressure will not be applied here, no any disorders of the metabolism will not have, no any problem. But if it is big pressure place, you will try to not remove the periosteum. Instead of it, you can make, for example, subperiostal method. What does it mean? Here you cut the periosteum little bit below, 1 centimeter below, to the future level of the cutting bone. You disconnect it peritoneum, like your sock, you lift it upwards. Above it, you cut the bone, and then you turn the tips of this periosteum and insert it inside of the bony canal. Then periosteum from downwards cover the bone tips. It is stop any regeneration here. And then from second point of the view, of course, it is the prevent any metabolical disorders, any supplemental disorders. What is the disadvantage of this method? Of course, you understand, guys, if there are exactly decision of the level, if you cannot make below this level, taking of the periosteum, because it is absent, it is, for example, crushed, or it is necrotized. If in that case I must do shortening extremity to take the preficit of the periosteum. You understand?
Yes.
For example, I decided this level of the bone, If below this level we don't have normal periosteum, it means I must to cut now bone above this level. To make shortening of the extremity, to achieve the preficit of the periosteum, which I will use for the future manipulation. That is only, the method is great if it is possible to take the periosteum from the decided level. But if it is impossible, it is impossible. What can I say? The worst variant, guys, then you cut bone and periosteum in the same level. In that case, again, I say, due to the regenerational processes, we can have formation of the scars. And in the future, during the pressure, they will damage the soft tissues and can make the disorders. Okay, let's continue. Now, according, guys, to the tissues which is included inside of the flap, of course, it is the worst one, just skin flap. Why it is the worst one? Because you don't form the big bulk of the soft tissues to close the tip of the bones. If it is only skin, easily bone tips can damage it in the future, to formate it some ulcers, necrotization, anything else. Next one, it is so-called myocutaneous flap. Good flap, guys, if it is for part of extremity without big pressure. The same upper extremity. What does it mean? Inside of the flap, you included muscles together with the skin. a big enough thickness of the soft tissues, which is cover the tip of the bones, which is prevent any I don't know, ischemical disorders or anything else. But unfortunately, from the point of the view of compression, again, not enough to prevent the crushing of the tissues under the bony tips. From that point of the view, osteocutaneous method is the best method. What does it mean? Inside of the flap, except soft tissues, we included also some bony structures. It can be patella, it can be sewing. Again, for example, I decided that this is the level of the cutted tibia and fibula. I want to make, for example, osteoplastic method of the amputation. Unfortunately, again, guys, if I cannot below this place create the normal bony plate, I must to cut the bone higher. That is the biggest disadvantage of this method, yeah? Because maybe below this place we have necros, osteomalacia, we have the, I don't know, different kind of disorders. If bone is normal, no problem. From the medial surface of the tibia, I will sew some, for example, bridge of the bone. Then, by this bridge of the bone, I will close the tips of two bones, the tibia and fibula, for example, yeah? And what it will give? Great, firm, we can say, base for the stump in the future, and it will prevent the crashing disorders of the soft tissue during the compression. Because you know physical rule, the more is surface, the less is pressure. So in cutted bones, surface is very small because they have the thin margins. But then you put this bony structure, bony bridge, below these cutted bones, you make protection. For example, I show here for you the beer amputation. Exactly, you can see. Yeah, for example, we make the decision. This is the level of the bone cuttings. Below this level, you can see we forms approximately 5 centimeter plate from the anterior medial surface of the tibia. Yeah, I sew it disconnected from the, I take only compact layer. I don't need here the red bone or yellow bone marrow. I don't need it. Just I take the compact layer and I don't cut the periosteum, which is connected this bony plate with the main level of the cutted bone. Let's say main bones, I cut it here, but I don't cut the periosteum. After this, from the skin and the soft tissues anteriorly, I make one big flap. It is single flap method, yeah? It is equal to the 1/2 of the perimetrium of the extremity. Measurement methods, I give it for you. So one big flap from anterior surface. In the posterior surface, we cut the structure in the same level. Then you cut it the bone, you put first of all the bony plate below the tips of the tibia and fibula, and by these soft tissues you close the final stump. Finally you suture the structures in the posterior surface, means the final scar will be in the posterior surface. For example, if it is the amputations of the thigh region, especially middle lower thigh, we can preserve here the patella.
Yes.
We included this patella inside of the muscular flap because it is connected by the proper ligament, by quadriceps muscle, yeah? And usually for the inner surface of the patella, we give the sharp form. Why we do it? To insert this sharp inner surface after inside of the canal of the femoral bone. Even by the hammer we can push it into the canal of the femoral bone, and it will make again the great, we can say, protection for the soft tissues of the stump and prevent the crushing of it.
Yes.
If, for example, you locate it in upper layer and don't want to make circular, you want to make the flap method, again, now here from femoral bone, you can sew the same plate and you can close the inferior surface simply, no any problem. Again, I say circular one is not the best method. just for simple prothesing if the pressure will be applied from down.
Yes.
Because final scar located in inferior
Inferior
surface.
surface.
Doesn't matter, guys. You can easily flap method use for the single bone regions. No problem. It is no problem, absolutely. Flap method we can use everywhere. Another question, that circular method I cannot use for the extremity with more than one bone. That is another problem. And finally, let's come to the leg amputation by Piragov, by different authors. We have it, yeah, for Chopard and another methods. Generally, what is same method, yeah, for example? What is the main specificity? All these methods, guys, which is shown here, doesn't give the shortening of the extremity. Why? Because then you, now look, for example, here, yeah, the Piragov method. What is the main advantage of this method? First of all, you make two incisions, as you can see here. One is located transversely, second one is located vertically, yeah, or we can say frontally. Frontal one and transverse one. By this transverse one, guys, you come to the malleolusis, and in the level of the malleolusis, you saw the tibia and fibula, for example, yeah? In the frontal level, you can see we come to the tubercalcaneo, and in this level, obliquely usually, we cut it, the calcaneal bone, and what is happen after? Then you turn this heel region to in front. Final length of the extremity is not decreased. Do you understand me or not? Now 1 minute, again, I will show you myself. Now this is first incision. By this access, you come to the leg bones, and you saw the leg bones by horizontal direction. Second, your incision, located in frontal plane. You cut the calcaneus bone approximately in the level of the upper and middle third of its length. Tubercalcaneum with the Achilles tendon, which is fused with it, it is preserved.
Yes.
All another part of the foot, by these two incisions, you disconnect it in the level of the tarsal bones and you remove.
Yes.
What are you doing next? You take this heel and you turn it
Yes, yes.
from back
to the in front.
to in front.
Yes.
And you connected this cutted calcaneus with the tips of your tibia and
Yes,
fibula.
fibula.
One big disadvantage, guys. If you will cut really vertically, Achilles tendon will become to the inferior surface. And always during the pressure, it will be compressed, and the bursa, which is located here, will be inflamed. Let's say instead to make absolutely vertical incision, we make oblique incision, and here and here. In that case, then you make turning, it is come in 60 degree to in front, and calcaneus is live in the inferior but posterior surface. Not exactly into the inferior surface.
Yes.
You understand me or not? Instead to cut vertically and frontally, this one you cut oblique, and that one you cut oblique. Oblique, then connected to each other. Finally, Achilles will come to not inferior surface, but inferior posterior surface. Here you can see angle, and here angle, which is directed to in front, which is directed to in front, which is directed to in front. Then these two you connect to each other. Achilles tendon little bit become to down, but not completely
inferior.
If you will cut it in this red line direction, then you will turn this one to upper red line. Achilles totally will come to the inferior surface. That is the best benefit of these methods. It doesn't give the shortening. Let's say, to tell the truth, instead of the prothese here, you need the orthopedical some shoes, which is much more easy, and of course the movements by this kind of the more than 150 years of this surgical operational history. Piragov, you know, it is the first person who made the amputation. Let's say this is me, great, really very great Russian surgeon. So historical purpose for vascular sutures. tendon sutures. Let's start from the chiral vascular suture. Of course, I must show it practically. But general rule is simple, guys. You must connect it intima to intima. This is very important. If I make the suturing of the vessels, I must make not invagination but exvagination. Technically, we have the stapler suturing machines. We can make hand suturing. In case of hand suturing, always we try to apply non-interrupted sutures, yet to not have any apertures between the neighboring suture. Suture step here is approximately near 1 millimeter. First of all, your assistant apply 3 fixator sutures, as you can see, for example, in this picture. Let's say this is 3 fixator sutures. Then on the angle between each one, it is 60 degrees. 60, 60, 60. Sorry, 120, 120, 120. 360. You divide it into 3 segments. Yeah? Then your assistant tends from these fixators. Inner wall we come to outside, and consequently 2 inner surfaces touch to each other. And segment by segment, for these 3 segments, you start. Then you reach to the fixator sutures. You make the knotting with your fixator suture and your thread to make the fixation of it in its place, and continue goes to. We have also the automatical suturing machines. I will show, I don't know, I might show or not. It is, for example, Daletsky machine, which is worked by the just simple stapler method. There are 2 rings. You open the ring, you apply it on the vessels. For example, this is the vessel. You put the ring in the tip of the vessel, one in the proximal, one in the distal. These rings have sharp tips. You take the vascular wall and you exvaginated it from inside to outside and fixate it by the sharp tips of the rings. That's like you achieve something like this. Yeah, it is one vascular wall. That's like you do it like that, and then you fix it to the tip of the, like it is very sharp tips. Yeah, then you fix it to the tips. After this, you connected one ring to another ring, and then you compress the rings to each other. It has stapler. From one side to another, metallical wire is go, and it, of course it is for big vessels. Yeah, for small vessels you cannot do it. Yeah, usually, but generally it is connected intima strongly to the intima. Of course, again I say you. Alexis Carrel, it is just the first person who describe and give the scientific rules. Yeah, I write it here. It must to keep the intima smooth. It must to be hermetical, not to decrease so much the lumen of the vessels, not to disturb the vessel supplyment, because vasa, vasorum, as you know, yeah, they supply the vascular wall. Yeah, and finally it must be technically maximally easy, because you work with small structures. Of course, usually we use some magnificational equipment, some microscope or something like this to see. Of course, only atraumatical needles. And of course, we use here the monofilament threads, yeah, because otherwise between the threads, the liquid can leaking. We can have liquid, or bleeding can be continuous. So we will speak about it. About the sutures of the tendon, here there are one problem, guys. Inside of the tendons, we have fibers. And then you apply the suturing of the tendon. You must understand that you can split it, tendon into the fibers. It is the problem. That's how we can. First of all, you must remember that there are 2 types of the tendons. Tendons inside of the synovial sheath and tendons without synovial sheath. Especially, I need marker, guys. Just 1 minute. I will go to my room. Here we must mention. Problem number 1. If you will provide the thread parallelly to the fibers, during tying of the knots, you can split it, the tendon, into the fibers. That is problem number 1. Problem number 2. If it is tendon which is located inside of the synovial sheath, you must keep absolutely smooth surface of this tendon. Why? Because if in the surface, for example, let's imagine that this is the tendon inside of synovial sheath. If I will apply final knot in the surface of this tendon, during the work of this tendon, it will slide up and down, and it will make the damage of the synovial structures. Finally, what will be happening, guys? Consolidation, they will be fused to each other, and function of the tendon will be loose. What I can do to prevent these problems? Let's draw, for example, the tendon. This is proximal. This is there are the different method of the Duchenne, method of the Cuneo, different methods. I will show for you the practical point. Now look to me. First of all, I will insert it. Most simple, what can I do? It is to insert, for example, a thread in one, to remove from another, and to tie the knot. But I will violate the two rules which I said before. First of all, my threads will be parallel to the fibers which is located inside of it. You see, this is direction of the fibers, that is direction of your thread.
Yes.
First of all, then I will tie, I will split easily, and my suture will come to outside.
Yes.
Will not give any fixation. And second, my final knot will be in the surface of this, even if it will not be splitted, for example, it will be in the surface of this tendon, and will damage the synovial structures during the work. How to prevent this? Look here, please. I will do my best, first of all, to not split, and secondary, to not make the knot in the surface of it. Instead of one needle with the thread, I will use two. Here it's not important, is it mono or polyfilament? Generally it is a traumatical, and usually, guys, we use here straight needle, not curved needle. Why straight needle? Because you will longly insert the needle inside of the thread. Now what I will do, one needle I will insert it approximately half of centimeter above the upper proximal, another half of centimeter below the lower distal, yeah? Now guys, techniques can be different, but approximately all of them is same. I must to try my best, first of all, to not split the tendon into fibers, and final note, I must to try my best to have between these tips of the tendon, not in the surface, but between. What I can do in that case, obliquely, each tip of this needle and thread has the needles. Let's say two here, two here. Obliquely, I remove it from the tip. Same obliquely, I remove it from the tip. Now, between these opposites, I tie the knot. Then these two tips will be connected to each other. Knots will be closed between these two tips. More of this, you can see that my thread has not parallelly to the fibers, but obliquely to the fibers. That's why then I will tie it. I will not split it into the fibers. Let's say keep it in your, again, you can see different mechanisms, of formation of it, but generally rule is same. And that is if it is tendon without synovial sheath, like Achilles tendon. Here you must remember just about one rule. Don't split it into the fiber. Let's say providing the needle into the tendon, not the parallelly, but in the oblique direction. No any problem. Is it understandable? Do you have any questions to me? That's all. My congratulations. Generally, we finished to study together all topics. What can we do after? Sit down, read. If you will have any question to me, I will be happy to answer. In the last 20 minutes, or half of hour. No any question? Friends, I will be in my room. Keep silence, please. Don't go outside. If you will need anything, just come to me.